When making decisions about adjuvant therapy for patients with high-risk melanoma, several things have to be considered. First of all, we have to determine what the predicted risk for relapse is in a given individual patient. We have to also look at the toxicities of therapies being discussed and also look at the efficacy of the different therapies. It's a little bit of a challenging time right now because predicting the risk for relapse is somewhat in flux. There's a new AJCC staging system that was just published in January of 2018 where the stage 3 patient population is doing much better because they're mostly patients with microscopic sentinel lymph node positive disease. So their risk profile is not as great. So the need for adjuvant therapy is not as universally accepted, particularly for the lower risk stage 3 patient population. Then there's the issue about whether or not they have BRAF mutation. Certainly, if they don't have a BRAF mutation, they could only be eligible for the immunotherapy adjuvant therapy, and that would be nivolumab and then likely pembrolizumab after it gets approved by the FDA. Because the trials included completion lymph node dissection for patients who had microscopic positive sentinel lymph nodes, that becomes an issue because recent trials looking at the role for completion lymph node dissection in patients with positive sentinel lymph nodes shows no benefit for performing the completion lymph node dissection. So there's another issue in making decisions about adjuvant therapy for patients, whether or not they should undergo a completion lymph node dissection after a positive sentinel lymph node. Given that there's no apparent survival difference in patients who underwent the completion dissection, it's not likely that that dissection contributed to any survival improvement in the adjuvant therapy trials. So it's probably safe in selected situations to not completely recommend a completion lymph node dissection for this patient population. After the surgery is completed, then there has to be a decision about using adjuvant therapy. It's the surgeons that usually identify the patients who are eligible, and then they would refer these patients to the medical oncologist. On a personal level, I would have to say that because of the BRAF-MEK trial showed such an amazing reduction in terms of number of events in terms of disease-free survival, and that the therapy is relatively well tolerated, that my personal first choice, if they were BRAF mutated, I would probably choose a BRAF-MEK combination. Most of my medical oncology colleagues, however, like to start with immunotherapy first. But I'm pretty impressed with the adjuvant therapy results using the targeted therapy of the BRAF-MEK. Now, in terms of toxicity, higher number of events in terms of patients discontinuing the BRAF-MEK therapy compared to nivolumab or pembrolizumab. But on the other hand, for patients who do have side effects that are mostly immune-related, they're usually long, life-lasting. Particularly if it's adrenal insufficiency or hypothyroidism. And the worst possible event would be diabetes. And these events are immune-related and probably don't go away after stopping the drug. So you have to kind of weigh the risks and benefits when you're making decisions about targeted therapy versus immune therapy, maybe higher toxicity in terms of discontinuation with the targeted therapy, but the side effects for the immune-related events are very long-lasting and probably for the entire life of the patient. So particularly for patients in the adjuvant setting where many patients are cured with surgery alone, these are very challenging decisions to be made in terms of establishing risk and also looking at toxicity. And then we have to worry about what happens when patients are taking adjuvant therapy and they relapse. So what do we do in that situation? Is it possible that they've already received an immunotherapy, that they would not respond if they develop distant disease? And the same thing may be true for targeted therapy. Probably what's going to happen with the immunotherapies that if patients relapse, and if they have surgically resectable disease, they'd probably then receive ipilimumab in the adjuvant setting because that would be also approved in the past, but have a higher toxicity. When we're looking at toxicities, particularly related to ipilimumab, probably pretty well tolerated in the stage 4 setting, but interestingly enough, in the adjuvant setting, seems to be a little more toxic. Not clear what the mechanism of that is. Now understand that the ipilimumab that was initially approved in the stage 4 setting was a 3 milligram dose. The 10 milligram dose was also tested as well in the stage 4 setting and was certainly had a higher toxicity profile. In the adjuvant setting, the 10 milligram is what's approved. And those patients had a pretty tough time. As a matter of fact, there were 8 deaths on one of the trials, which was the ECOG 1609 trial, that looked at high-dose interferon versus low-dose ipilimumab versus high-dose ipilimumab. And the toxicity profile for the 10 milligram dose was very high in the adjuvant setting. In terms of BRAF/MEK, it looks like the tolerability is pretty much the same in the adjuvant setting as it is in the stage 4 setting. Pembrolizumab or nivolumab, probably similar toxicity profiles in the stage 4 setting as it is in the stage 3 setting.